going to sort of give you some interim results of the clinical performance study that we've been doing in Zambia. So the objectives basically of this study was to determine how well does a user, how well is a user able to use this oral self-testing kit, comparing the results that they obtained with the results of a laboratory-based testing regimen. Also looking at the agreement between the results obtained by the user in the field with that of a professional user using the rapid diagnostic test as we have in the Zambian algorithm, as well as comparing the three. And then also assessing the user competence in actually being able to perform the test using the instructions for use that are provided with the test kit. And then looking at the ability to interpret the results of the test compared to that of a professional user. And then also looking at the stability of this test kit after it has been done, using looking at the stability in the results, looking at the delayed visual rereading study after about 12 months. So this algorithm basically shows the study, and I think it's a bit faint. So basically we had two communities, urban community as well as the health facility testing, and provided the questionnaire as well as consent, and then provided the test kits to those who accepted to do the test. And in the first round of testing we did, the users were provided with the instruction for use with no other instructions, and then asked to do the study, and then a research assistant redid the study and reread the results. And then blood was drawn from the participants for a rapid diagnostic test as well as for further laboratory testing. And those who were found to be positive with the rapid diagnostic test were referred for care, bearing in mind that the oral fluid test is more a screening test as opposed to, you still need the confirmatory test. This slide basically shows the algorithm that we used in the lab, where if there was any discrepancies between the rapid diagnostic test and the lab test, the tests were exposed to further testing using third generation test kits. So in Zambia, we had two sites. We had a rural site, which was mainly community-based, and then we had an urban site where we had both the health facility testing as well as within the community. We had a target of 3,250. And for each site, we had two teams, two research assistants and one research nurse. In the community, these teams visited all homes in the zones, enumerated the household members, and offered self-testing to the eligible household members. The study began in May 2016, and we had all the sites active by August. And as I said earlier, in the initial procedure, the self-test was provided with the instructions, and the people were asked to actually read or follow the instruction for use. We did an interim analysis for the first 58 using both the videos. We had some videos that were done, as well as cognitive interviewing. And I think the two presentations before, I think, highlighted some of the issues that we found in the analysis of the ability to take the kit and actually read the instructions. And some of these were inability to open the pouch, inability to understand even the pictorial representative of what it meant to swab the gums, as well as timing and that sort of a thing. And we looked at the results of this initial first 58, and the sensitivity and the specificity were very low. So we then revised the procedure and had a standardized list of instructions that the research assistant provided to the client, giving them the steps that they needed to follow in carrying out the test. So between July 2017 and July 2016, and March 2017, we have had about an average recruitment of just slightly over 200 participants per month, and we have just slightly over 2,000 participants at this moment in time. Looking at the distribution between the sites, we have more participants from the urban health facility, followed by the urban community, and then the rural community had the fewest number of participants. Looking at the participants that we have recruited so far based between male and female, and I think this was brought up earlier this morning as well. Females have a greater representation in our sample, and interestingly enough, the rural facility, there's very little difference between the male and female distribution, but in the urban sites, the females are about 2/3 of those of the males. We had planned to videotape at least 100 of the initial clients. However, we've had problems with actually getting people to consent to the video. So at the moment in time, we have 91 videos that are available, and we found that there's greater acceptability in the urban center than in the rural center. We are still to analyze these videos, but an initial the initial look shows that there is still some inability to understand the procedure and do it accurately despite the instructions. Then presenting you the results of the 2,052 participants that we have up to last week Friday, looking at the agreement between the results obtained by the user and that of the professional user with a rapid diagnostic test. And in this slide, we can see that there's pretty high agreement between the results obtained by the user as well as that from the rapid diagnostic test, with about 99% accuracy and the sensitivity of about 94% and almost 100% with the specificity. I then present the results of the 1,080 participants from whom we have both the results of the rapid diagnostic test as well as the laboratory algorithm. This is much less than I presented in the previous slides because we have not completed all the laboratory testing. And even with this slide, we can see that there's pretty high agreement between the client-administered read results as well as that of the laboratory test algorithm, with agreement almost 98% and pretty high sensitivity and specificity. We have also begun a visual stability study. So this is a situation where the used test kits are kept at the clinic at ambient temperature, and we're beginning to do a rereading of these kits. And we have this done mainly in the urban community testing, and we plan to do this between April and June. So we have the kits that are stored at the ambient temperature, and then we have they're being reread by 3 different people, and we have a schedule for rereading. So each one will be read daily from day 1 to day 7, and then monthly. And then we enter the results into the device. This study began on 14th of March, so we don't have many results at the moment. So some of the challenges we faced in actually doing the studies, our rural site is pretty vast. It's a large area with lots of distances between the homes. It's also a farming area, so we began our study in May, June, and July, August is probably the harvesting time, so many people were not in their homes as the research teams went around. And then we went into the rainy season, which is also a farming area, a farming period. In our urban site, we had quite a few interruptions during the election period in August, and we also had to actually reconstruct a facility to do the testing, so hence some delays we had there. So in terms of where we are at the moment, we will continue this study until the end of June this year, and then hopefully soon after that, we will be able to have more definitive results for the total sample size. Thank you.